Okay, this is drugs for the gastrointestinal problems, chapter 13. Okay, so gastro drugs for gastrointestinal problems. Okay, so let me see what I have here so we can get started. Great. Okay. So again, you want to review your key terms, okay? And so the digestive system. So just kind of do a quick overview of the digestive system itself. Um, it's composed, you have the mouth, you have the esophagus, the stomach, the intestines, other accessory functions that you see here in figure 13.1, that's in your book, and also here on the page. And what the system does, it performs both mechanical and also chemical processes of digestion. You also have it also can absorb the nutrients that you intake, and the last part would be to eliminate waste. So, um, you know, um, it's inside the body, and this is where the digestive system is. It's mostly mainly inside, but it is in constant contact with the external environment. For example, you're eating, and then you're actually, eliminating things outside of your body. So it goes in, it comes out. So so those are your basic parts. So I'm not going to go too much into the digestive system. That's more of anatomy and physiology. So right now we're just going to really kind of look at some of certain medications and everything that can bring you towards if you have any type of problem whatsoever. This chart here, it shows you the actions within the digestive system from ingestion of food and also water, and also absorption of water and nutrients, secretion of aids to digestion, and also removal of any type of waste product. So it's like a whole plumbing machine you got going on here. Everything connects, everything works together, and you have to have the heart to be there in order to circulate certain, things that come into your bloodstream to get out, to go in. You have to have the liver there to help with other, metabolisms. And then you have everything else. You have the stomach, and the intestines that's going to help you, absorb certain products. But of course, like anything else, if anything goes wrong, you have to have something to back it up. And this is when the whole pharmacology comes into place. Um, so it could be two different problems that the digestive problem can have, such as vomiting and also formations. And they have other problems that can include movement of the stomach, contents back into the esophagus, which you will see the gastric reflux. You'll have the abnormally slow movement of contents into the intestinal tract, which you will see the constipation, and also the abnormally fast movement of contents through the intestinal tract, which you would see actual diarrhea. So this chapter is going to focus on drug therapy, and this is going to prevent or manage these problems. So in addition to that, we're going to look at how the digestive system can become infected with bacteria, viruses, fungi, and also parasites. And drug therapy for conditions related to infectious agents is also going to be, we saw about that. Looked at that in chapters 5 and 6. So let's take a look at some of these anti-emetic drugs. And these are very common for the whole nausea and vomiting within the GI system. Okay, so this right here, this slide here is basically digestive system functions, the structures, the protective factors, and also other variables that you will see within the GI. So let's look at the antiemetic drugs. So you have the nausea, you have the vomiting, and these are your common GI problems that can occur as a result of an infection, and as a result of having maybe anesthesia given to you, or as a result of being exposed to some type of chemotherapy, for example, for cancer. So you will have that. So very often, nausea and vomiting, they do occur together. Sometimes you do see that, or either vomiting will actually follow the nausea. But however, nausea can occur without the vomiting. As you can see, some people go, and they bring it, but nothing actually comes out. But again, it's still a very unpleasant sensation to them. And so when you start thinking about these antiemetic drugs, we look at, what it can do to actually help with those symptoms. Um, so so again, you have the digestive tract, and they result from, and so you have the nausea and vomiting, and these are just some problems in the digestive tract, and they do result from a complex set of interactions that involve the brain, that's going to be involved. You have the nervous system that's going to be involved. You have the inner ear and the stomach and the intestines that's going to also be involved. And this is going to send a whole message to the cerebral cortex in your brain. For example, remember the flight and fight. When that signal is sent to your brain, you react, you like become very anxious. You either stand still, or you just flee and run, or you fight and do something else. So the same thing when you have that message sent to your cerebral cortex, you have, your sensory organs begin to give that whole, experience with the nausea and the vomiting and so forth. So in your book, when you look at it, it talks about, in figure 13, it talks about vomiting is a complex reflex. And it's going to involve stimuli to the vomiting center directly or indirectly through the chemoreceptor trigger zone. So it's going to trigger this, the CTZ. And you can see that many types of receptors are involved in vomiting. By understanding that there are different types of receptors, and you can understand that different types of antiemetics and how they work. So you're going to have these receptors. You're going to have something that's going to cause something. Now we got to take the drugs and find and get them to actually stop those trigger effects, and that's going to be your antiemetic drugs. Some of the drugs you're going to see are, like, for example, you have, when we looked at other categories, we've seen how you have some receptors such as the dopamines and the serotonins and the histamines and acetylcholins, how they reacted. And then we had to get drugs to kind of pace it down and slow that down a little bit. Always remember your top tip for safety. So the patient with nausea and vomiting are at risk for dehydration, weight loss, and also electrolyte imbalance. So you're going to monitor and you're going to report any of these changes in fluid balance, in food intake, and also laboratory abnormalities. Okay, so that's one of your top safety tips. So let's think, antiemetic drugs, a memory jogger, so you can remember these categories of antiemetic drugs. And these are going to be your serotonin receptor antagonists, your substance P antagonists, your phenothiazines, which is the dopamine antagonist, your cannabinoids, your promotability drugs, your butyrophenones, phenones, that category. And also your anticholinergic drugs. They're going to pop up again as being part of the antiemetic drug family. And you did hear some of these drugs in other categories of families too. And like I said, these drugs can, because of the cholinergics, because of the serotonins and the dopamines, you're going to have these antagonists, the things that's going to go against it to kind of, relax everything down. So let's look at the one category. You have your serotonin, your receptor antagonist, and okay, this is the mechanism of vomiting that's in your book also. So your serotonin receptor antagonist. So you have some examples of those. And your serotonin receptor antagonists, they help reduce or halt nausea and vomiting by blocking the SHT3 receptors in the intestinal tract and the CTZ. So serotonin cannot activate these receptors. And what kind of drugs you would see in that category? So again, you have to remember, you have to know those generic names. I will tell you the brand names. But if I can get those generic names out my mouth, we'll get that going. So you're on Desterone. Remember Zofran? Zofran is one of them. That's a serotonin antagonist. Do you have another one called Anzimet? And that's going to be your Dolacestrone. That's your generic name for that. A lot of these drugs are either given, for example, the dolacestrone is given 1 hour before chemotherapy, because you know that chemotherapy, when the patient takes that, it gives that reaction of feel that nausea and also that vomiting. The Zofran itself is it's a tablet that can be given 8 milligrams orally 30 minutes before chemotherapy, then every 8 to 16 hours after the initial dose. Sorry about that, everyone. And it also may be given, and you also may give the doses every 12 hours after chemotherapy. And this can be given, the Zofran can be given PO. I've seen it given through the IV. But right here, it's this particular one is given orally and 30 minutes before chemotherapy. So this is the serotonin receptor antagonist. Of course, you have your nursing implications. So you want to make sure that the patient has a call light available, because these drugs can cause a dizziness effect. Also, these drugs may be given for post-operative nausea and vomiting, but are typically given intravenously rather than orally if it has to be given that way. Then you have your category that still falls under your common antiemetics, and that's your substance P neurokin receptor antagonists. And what they do is reduce or prevent immediate and delayed nausea and vomiting by blocking the substance P neurokinin receptor in the CTZ. And this is going to prevent both of these substances from binding to and also triggering that CTZ. So just remember, the CTZ is the one that we said earlier, it's the one that's a receptor that helps kind of really begin that whole nausea and vomiting going on, because that's your chemo receptor trigger zone. So that's your CTZ, okay? So it's your chemo receptor trigger zone. So what are some medications you would see with that one would be your aprepitant, or either your amend oral, which is your brand name. And then you also have another one, it's 2 medications in that category. You have your Verubi, or your generic name for that one is the Rolapitant. So your nursing implications with those 2 medications, you always want to double check doses of the substance P neurokin receptor agonist, because protocols vary according to the potential of the chemotherapy drug and to cause nausea and vomiting. So more emetogenic chemotherapy drugs may require more frequent doses. So the stronger the chemotherapy drug, the more frequent doses of these medications you will have to give. Also, another nursing implication, in some cases, this drug may be combined with a corticosteroid agent to reduce some of the symptoms of the nausea and vomiting even further. Another category for the common antiemetics will be your phenothiazides. And their phenothiazides reduce nausea and vomiting by blocking the dopamine receptors in the CTZ. And you will see your compazines under this category, your phenigans under this category. And those are some very common medications you will see in a long-term care setting. You want to teach the patient to change positions slowly because, again, this can cause some type of orthostatic hypotension. So make sure you review your nursing implication in each of these categories because some of them could be different from drug to drug. Also, you want to remind patients that alcohol may increase drowsiness and increase risk for injuries. It's also another category of drugs for the antiemetics. This is very common. You see it a lot now. And I remember when it first started, when I was working in a nursing home, you have your cannabinoids. And these are either natural or synthetic forms of THC that reduce nausea and vomiting by binding to both the cannabinoid receptors in the CTZ and by interfering with the serotonin from binding to its receptors in the CTZ. And these drugs, you will see your dronabinols, or your brand name would be marinols. And then you will see your nabilones, and the brand name would be Sesamet. So you have those. So your nursing implications when it comes to taking these cannabinoids are typically reserved for patients who continue to have nausea and vomiting, who do not respond to other drug categories of the antiemetics. Also, the first dose should be taken on an empty stomach 30 minutes before meals. After the first dose, these drugs can be taken with food. You want to advise your patients to avoid alcohol, sedatives, or other CNS depressants because they may increase the risk for sedation when they're taking any type of cannabinoid. Then you have your pro-mobility drugs. And these are a class of drugs that increase contraction of the upper GI tract, including the stomach and the small intestines. They do this by blocking dopamine receptors in the CTZ and the intestinal tract. And this is when you're going to have your regular Raglan. You'll see that's the brand name, or the generic name for that one is the metoclopramide. So you'll see that. You have your Tigans, and your generic name for that one is the trimethyl benzamide. So you have those. And again, of course, they're going to have their own nursing implications, where you're going to monitor the patient carefully for any mood changes or restlessness, because these are common side effects, okay? And again, your memory jogger, always make sure you're looking at your memory joggers when you're looking at these certain drugs in their categories. So now, again, we're back to the serotonin receptor antagonists. And of course, they have their actions and their uses that you see here. And we did review that. Now, and we did see some nursing implications for that category. Now let's look at some expected side effects for these. So you have your common central nervous system side effects, and that would include your dizziness, the headache, and the drowsiness. And some patients experience change in taste, heartburn, or constipation. So those are some of your expected side effects. Adverse reactions would include allergic reactions, and you may see some dysrhythmias with that. With the serotonin syndrome, it can occur if the patient is taking other drugs that increase serotonin itself. For example, if they're taking an antidepressant like St. John's wort. So you want to be careful with that one, with the patients having those adverse reactions. Drug interactions can, you have because, these drugs, they can interact with a variety of drugs that already contain the neurotransmitter serotonin itself. So, for example, you have your monoamide oxidase, your morphines, and serotonin uptake. So you have those. So when it's combined with a phenothiazide drugs, the patient may experience some type of cardiac dysrhythmia. Okay. So again, you have your nursing implications, which are already in the drug category, so that you can continue to review. Also, box 13.1, it talks about general nursing considerations for antiemetic drug therapy. So it's a whole list of that you want to look at and you want to review. Okay. Now, okay, let's see. Give me a second here. Okay, so now let's look at a different category, the next one, which would be your substance P neurocanon. Let me just make sure. Your substance P um, neurocanon. And these are your receptor antagonists. We already looked at the action and the uses for those. So your expected side effects would be fatigue, diarrhea, headache, and dizziness are a side effect with this. And the patient may experience some type of mild hiccup, flatulence, and also sweating. Adverse reactions that you would see with this would be neutropenia is one of the most common adverse reactions associated with this, angioedema. Also, severe allergic reactions and respiratory depression can also occur. Some other drug interactions that you would see, and particularly these drugs, they interact with opioid drugs, causing increased dizziness, drowsiness, and also sedation. And also use of these drugs with certain benzodiazepines can increase the effect of the benzodiazepine itself. Should be used together with caution when you're using those two together. And of course, we went over some of the nursing implications, so you want to make sure you go and review the patient teaching, the nursing implications in regards to these drugs. The phenothiazides, we did look at the action and the uses already. Your expected side effects would be drowsiness, some blurred vision, dry mouth, and also some of these phenothiazides can cause urine to change to a pinkish red color. And also sensitivity to the sun exposure is also common with these. Adverse reactions to these phenothiazides are most common at higher doses. As a result, excuse me, of blocking dopamine, the patient can experience EPS, which is extrapyramidal symptoms that we talked about in earlier chapter 10. And you're gonna see these. You can see that tardive dyskinesia, the acute dystonia, and even some neuroleptic malignant syndrome. It's also some blood abnormalities are also possible while the patient is on these phenothiazides, so it should be avoided with patients who have cardiovascular disease, only because these patients can experience angina, tachycardia, and also orthostatic hypotension. Drug interactions you will see. It does have an interaction like a whole wide variety of drugs. So they should not be given with Reglan, which also affects the dopamine level. So the phenothiazines can increase the effects of any other drug that affects dopamine, including those monoamine oxidase inhibitors and several other antidepressants. And phenothiazide should be avoided in patients who are taking any type of levodopa or carbidopa for Parkinson's disease. And again, you do have your nursing implications that you want to review with that we saw earlier in regards to this group of medications. Your cannabinoids, excuse the slide, looks like it kind of went out of place a little bit, but your cannabinoids. So the actions and uses for cannabinoids. So marijuana itself is a common street drug recently approved in some states, and I'm reading this from your book, in some states for use for medical treatment of certain health problems, has been used to help control nausea and vomiting associated with cancer chemotherapy. Although many chemicals are present in marijuana, the ingredient that has the antiemetic actions is the tetrahydrocannabinol, which is the THC. So all humans have a THC receptor in many areas of the brain, including the CTZ and also the pleasure centers. So those cannabinoids are drugs that are either natural or synthetic forms of THC that reduce nausea and vomiting by binding to both the cannabinoid receptors and also the CTZ receptors, and by preventing that serotonin 5-HT3 from binding to its receptors in the CTZ. So the use of cannabinoids can be used as an antiemetic. It's typically reserved for patients with nausea or severe nausea and vomiting that has not been relieved by any other antiemetics because of the potential for an addiction, which is possibly can be rare, and also other side effects. Table 13.1, it did list the names of the medications that we showed that fell under the cannabinoid subsection, and it also showed the nursing implications for that. So your expected side effects. So the most common side effects are related to the effects of the cannabinoids, which is going to be on the central nervous system or CNS. Some patients may say they experience a high or easy laughing or some type of elation, and also or some type of increased awareness. Other CNS effects are dizziness, anxiety, insomnia, and difficulty concentrating, and also mood changes. And some patients may experience some type of emotional lability, and like, for example, wide swings in emotions. And these side effects may decrease after 2 weeks of treatment. And some patients have GI side effects, such as the nausea and the vomiting, and also abdominal pain. But one thing you would see in older adults, and you have to monitor, is their orthostatic hypertension, okay? And you do have your adverse reactions. You have your adverse reactions, which does include acute confusion, hypersensitivity, and seizures. Seizure-like activities that have been known to be seen in some patients. You rarely you see hallucinations, excessive sweating, or fainting, but this can happen. And again, you want to monitor your patients closely. And these drugs should be used with caution in a patient who does have a history of any type of substance abuse, which includes alcohol. Okay. Drug interactions, it can interact with a variety of drugs, this category of drugs. So Coumadin or the warfarins, the calcium channel blockers, the opioid and agonists, and a variety of antiretroviral drugs used for HIV patients. Patients who take the dronabinols should avoid any type of grapefruit juice because it can increase adverse effects for this. And again, the nursing implications and the patient teaching, you want to make sure you go through that and you review those, okay? Then you have your promotility drugs. Again, we looked at those, we looked at the actions and the uses. And the most common side effects with these would be your drowsiness and some restlessness. And some other ones would be, like, one would be visual impairment, urinary incontinence, and also insomnia. Adverse reactions with these drugs should be used with cautions, especially patients who have a history of depression, because it can cause even more depression and also suicidal ideation, as well as seizures, blood disorders, cardiac dysrhythmias, and also heart failures. There are other adverse side effects to these drugs, so make sure you go through it and you review those. One of them, for example, the neuroleptic malignant syndrome is a rare life-threatening reaction to the drugs that decrease dopamine. So you want to just kind of continue to review and read those, okay? And again, you have your drug interactions. So promobility drugs are contraindicated in patients who are taking any type of phenothiazide drugs, and we just say that earlier. Typical and also atypical antipsychotic drugs, and also the levodopa and the carbidopa drugs. In addition, the use of these drugs along with certain antidepressants can increase the risk for serotonin syndrome also. And so those are some of your drug interactions. And of course, with the nursing implications, again, we just see those when we looked at the category of drugs earlier. So now let's look at drugs for peptic ulcer disease and also esophageal reflux. Again, this is where you're going to see your antacids, your histamine H2 receptor antagonists, your PPIs, proton pump inhibitors, and your cytoprotective drugs. So drugs for the peptic ulcer disease, again, the lining of the stomach, it's going to be affected. Gastric distress may be the cause of it, especially when you get stress or disease producing excess secretion of these gastric acids, or when alcohol, chemical drugs, or diseases produce destruction of the protective mucosal lining itself. Okay, so as one of the memory joggers, make sure you look at this. The prostaglandins maintain good blood flow to the stomach, which keeps these tissues well oxygenated and allows the immune system to help keep them healthy. And this is why drugs that decrease the prostaglandins, such as corticosteroids and the NSAIDs, can be harmful to the stomach. So many people, you have other problems that will fall under this. You have your peptic ulcer disease, your GERD, your gastric reflux disease, when it's very acidic, these contents move backwards, and it causes that reflux into the esophagus. So the esophagus has no protection for this acidity, and it can damage very, very easy. So let's look at some of these. Drugs. Okay, and this is the peptic ulcer pathophysiology that you'll see in your book, and also the pathophysiology of GERD. Okay, so let's look at some of these drugs and where the category, what they do, and the medications that they have, and some of the nursing implications. Okay, so your common drugs for the peptic ulcer, you'll see that in table 13 too. Okay. And these drugs neutralize stomach acids to help relieve heartburn and also indigestion. So you're going to see your, your Rolaids in this category, your milk and magnesia in this category. So these fall under antacids. And again, these drugs neutralize stomach acids to help relieve heartburn and also indigestion. So one of your nursing implications would be antacids are often available as combination drugs. So make sure to review drug information carefully before you actually give that to your patient. Patients with heart failure or any other cardiac disease should avoid antacids high in sodium. Okay. Then you have another category, which would be your histamine H receptor antagonists, and these drugs bind to the H receptor in the stomach cells, leading to a decrease in production. Okay, let me go there. Leading to a decrease in production. I'm just looking for that one. Sorry about that. I should have came up like that. Okay. Okay. So skip some. Okay. And so it's histamine H receptor antagonists. These drugs bind to the H2 receptor in the stomach cell, leading to a decrease in production of basal and nighttime gastric acid. They also decrease the amount of gastric acid that is released with meals with substances such as caffeine. And then you'll see your Pepsis, your Zantacs in this category. And these are a lot of them are over the counter drugs. So, as a nursing application, over the counter doses are typically about half the prescription drug doses. Patients who are taking over the counter histamine H2 receptor and antagonists should not take them for more than 2 weeks without seeing a healthcare provider because they may be experiencing a more significant health issue. So you want to make sure. And also you're going to monitor the patient for signs of restlessness or confusion because these are some of the side effects and the patient can be at risk for falls. Your proton pump inhibitors. So these drugs help heal gastric ulcers and also reduce symptoms of the GERD by stopping the acid secretory pump that is located within the gastric parietal cell membrane. And this helps reduce the amount of acid secreted in the stomach. So you have your Nexiums, you have your Previses, your Prolacets here, and your Protonex. So you'll see that. You see a lot of that within the long-term care facility. You'll see those. You want to give these with a full glass of water for 30 minutes before meals for maximum benefits. Also, make sure you read the drug information carefully prior to giving these. Teach the patient it may take several days to experience relief once beginning a proton pump inhibitor. Okay. And also, if the patient has H. pylori bacteria in the stomach, the proton pump inhibitor will be combined with specific antibiotics to treat that infection. So remind them to take the medication, the whole full prescription for that. Then you have your cytoprotective drugs. And these drugs protect the lining of the stomach and protect them from further damage. So when taken properly, some of these drugs can stick to the ulcerated areas in the stomach or duodenum to protect them from further damage and allow them to begin to heal. And this is where you see your Carafats, your Pepto-Bismols, and your Cytotex. So all these names will be so familiar to you. These are the brand names, but you begin to learn the generic name as you go along. So the Carafats, the generic name for that one is the sulcrafate, that category of drugs. So your nursing application is a few of them, so like more than a few, but do not give antacids within 30 minutes before or 1 hour after the Carafat because they can decrease its effectiveness. Also, these drugs, you do not crush them or chew these tablets. You want to shake the oral suspension well before giving them. And again, like I said, it's quite a few. And also, if you want to encourage the patient to drink at least 1 to 3 liters of liquid, unless contraindicated, because this drug can cause constipation. And again, of course, you have that lovely memory jogger here in your book. The common drugs used to manage peptic ulcers and GERD are your antacids, your histamines, your PPIs, and your cytoprotective drugs. And again, for your antacids, we already looked at the action and the uses. The expected side effects when you're using an antacid, when you're using it, in general, like, if you're using it with magnesium, it can cause diarrhea, brands with calcium or aluminum can cause constipation. Other side effects include loss of appetite, frequent burping, nausea and vomiting, fatigue, and also weight loss. Adverse reactions, you will see usually specific to the type of the antacid itself. And your book is a great example. It says, for example, the patient is taking magnesium-based Antacids. Adverse effects are usually related to increased or hyper magnesemia, or aka muscle weakness. You can see low blood pressure with this, and also low heart rate with the hypomagnesemia. Okay, and there's some other adverse effects that you can also review with this, along with this too, especially if it's effects of calcium that contain calcium. The calcium containing antacids. Okay, so you want to make sure you review that. Some drug interactions. A major concern for all antacids is the impact on absorption of other drugs. For this reason, timing of administration of antacids related to meals and other drugs is very important. So you always want to consult your drug reference book in regards to that. And of course, the nursing implications and the planning implementations that you want to review. Okay. Nursing considerations for the patient with peptic ulcer disease or gastroesophageal reflux disease. You'll see that in your book in box 13 too, where they review all of this. Again, for example, teach patients to avoid eating within 3 hours of bedtime to reduce the risk of reflux while lying flat in bed. Okay. Okay. And here are some of your nursing implications and some other patient teaching. Okay. Also we're still under the same category, your histamine H2 receptor antagonists. Again, we looked at the actions and the uses. The expected side effects would include your headaches. And some patients may also have a mental status change, and also signs of depression. And if they do, it's resolved usually when the drug is actually stopped. Adverse reactions, are rare and include some severe reactions. So a variety of blood disorders, and also cardiac dysrhythmias are noted. Although the reason is not fully known, patients may also be at risk for pneumonia. Okay, and you do have some drug interactions, and the H2 blockers can affect certain enzymes in the liver that metabolize drugs. This can result in changes in how certain drugs are metabolized in the body itself, and that includes your warfarins and also some of your calcium channel blockers, and also alcohol. Do you have your protein pump inhibitors? And some of those expected side effects would be, again, your headache, some mild abdominal pain. And also you may know the patient may have constipation. And many patients experience increased sensitivity to light, which is the photo sensitivity. And it's less common side effect. One of them would be dizziness. Okay. And then you have your cytoprotective drugs, and we already went over. So some of those actions and also the uses. Okay. So now your next category would be drugs for constipation and also diarrhea. So constipation, is not considered a specific disease, but it rather is a condition associated with other health problems. And as you're seeing, a lot of times when you take certain medication, it affects that. So normal bowel patterns, normal bowel patterns vary widely, with some people having bowel movements several times a day and others no more than 3 times a week. So decreased frequency of bowel movement is just one factor associated with constipation. Others include hard or dry stools, pain without having a bowel movement, and also some type of feeling of bloatiness or straining during a bowel movement. Okay. So you have certain drugs that you want to use for that, but you're also going to have your memory jogger just so you can know your signs and your symptoms of constipation. So signs and symptoms of constipation will include less than 3 bowel movements per week, harder stools than normal, and also feeling bloated, like we just said earlier. Okay. And like constipation, you do have diarrhea, and this is and diarrhea is common. It's a common symptom. You know, it's a common symptom of other health conditions. Diarrhea is caused by an increase in the amount of water in the stool, and this increased water is from an imbalance between the amount of fluid secreted from the intestines and the amount of fluid absorbed back into the body. So the amount of fluid secreted is greater than the amount we absorb. Water will remain in the colon and the stool will become loose and also watery. Okay. So sometimes this can result in it can be a result of an infection. It could be drugs that can do this, an inflammatory bowel disorder, some type of food poisoning, or other medical conditions. So box 13 gives you the common causes of diarrhea. So you can look into that because there's different common causes for diarrhea, one of them including high dose radiation therapy. So what are your drugs for constipation? So you're going to have the different categories. So one of them would be your laxative. So you will have that. And also, and they all fall under different categories. So your common drugs for diarrhea and constipation that's going to help reduce either the constipation state that the patient is in or the diarrhea state with the liquid stool that the patient is in. So your anticholinergic drugs that falls into this category. So these drugs reduce diarrhea and associated symptoms by selectively blocking the neurotransmitter acetylcholine from binding to its receptors in the nerve cells. And the nerve fibers of the parasympathetic system affect the involuntary movements of the smooth muscles in the GI tract, lungs, and also the urinary tract. So you'll see one drug falls into this category, and that's your dicyclomine, which is your generic name for the medication. So with this drug, do not give this drug within 2 hours of giving an antacid because it can decrease absorption. That's one. Number two, do not stop this drug suddenly if the patient has used this drug for a long time. Suddenly stopping this drug may cause withdrawal symptoms, and including dizziness, sweating, and also vomiting. And also, to avoid local skin reaction with local pain and edema, you want to inject this drug into a large muscle mass. So that's your anticholinergics. Then you have your antispasmodic drugs that fall into these categories. And these drugs reduce muscle contraction of the GI tract, and this causes decreased cramping, bloating, and also diarrhea. And this is where you will see your atropines, your phenobarbital, your scopolamines, your hyoscyamine. So some of these drugs, they help decrease they help with the nausea and so forth too. For example, the scopolamine and your brand name for this one would be Donatol. So you have so many generic names for it, but your brand name itself is called Donatol. So you want to teach patients that they should not use contact lenses while taking these drugs because they can cause dry eyes and also blurred vision. And this is what the scopolamine does, especially the scopolamine patch. Basically what it does, it kind of helps to dry up and something, for example, because it helps reduce muscle contractions of the GI tract. This is going to cause decreased cramping, bloating, and diarrhea, but at the same time, it gives a drier up effect, especially if the patient is drooling or, they usually use that scopolamine patch. These drugs help decrease GI motility and should not be used in infectious diarrhea. You want to monitor the patient's vital signs while they're on these drugs because these drugs can cause a significant change in the heart rate and like such as bradycardia or either tachycardia. And these drugs are not recommended in an older adult because they can cause confusion and other adverse effects, even at a lower dose. Then you have your categories of the opioid agonists. And these drugs are synthetic opioid agonists to decrease the motility of smooth or motility of the smooth muscles in the bowels. So they're combined with atropine to help decrease any mood elevating effects of the opioid and reduce potential and reduce potential for abuse. So Imodium that you always hear used for diarrhea, Lomotil that's used for diarrhea. So you'll kind of get used to learning all these certain medications that they're going to use to slow down the motility of the smooth muscles of the bowel. So again, you want to remind patients to avoid any type of sedative, tranquilizers, and opioid pain drugs because they may increase the risk for the CNS effects. You have your bulk forming drugs. So anything bulky, that means it's going to help with the constipation. So these drugs act by absorbing fluid in the GI tract to form a mixture leading to softening and increased bulk in the stool. The increased bulk stimulates peristalsis, and this is going to lead to increased bowel motility, and also more rapid transit time through the GI tract. So stools are going to be easier to pass. And in addition, these drugs can be helpful for patients with watery diarrhea also by increasing their bulkiness and also in the consistency of the stool. So you're going to have your citrus cells, your metamucils. So you'll see that used for your patients so they can have a nice regular bowel movement every single morning. And you want to teach your patient that these drugs typically work within 12 hours to 3 days. So therefore, you want to instruct the patient to drink at least one full glass of water with each dose to avoid blockage in the esophagus. And these drugs can be mixed with water, fruit juices, milk, even milk for a better flavor, because some patients may ask for it to not be placed in water because they don't like the taste. So therefore, you want to put it in something else that'll kind of give a really nice satial taste. Then you have your emollients, your stool softeners. So these drugs lower the surface tension of the stool, allowing water and lipids to permeate the stool. This results in a softer, easier passageway for the stool. This typically takes at least 1 to 3 days for the patient to receive the benefits. And this is where you see your colace, your known name, or the docu-state sodium, or the docu-state. And you want to teach the patient that they may experience a change in urine color from pinkish red to a yellow brown, depending on the alkalinity or acidity of the urine itself. Okay. Then you have your stimulants, and these drugs stimulate peristalsis by irritating the mucosal lining of the intestines and increase the amount of fluid in the intestines by relaxing the bowel and also easing the passage of the stool. Then you're going to have your Dulcolax or your Bisocal, so you'll see those really frequently in a long-term care setting or a hospital. So these drugs are available over the counter and may be used for occasional constipation. A higher dose can be used for like a bowel prep. You'll see that, for x-rays or colonoscopy. And then you want to inform patients regarding the expected onset of action. For example, oral tablets can work within 6 to 12 hours, and rectal suppositories can work within 15 minutes or an hour. Then you have your osmotic laxatives. And these drugs can cause increased absorption of fluid into the stool. As a result, the stool is softer and distends the colon, leading to peristalsis and easier passage of the stool itself. Then you're going to see your miralaxes, your fleet enemas, and you will see that. So you always want to follow the directions very carefully when these drugs are used as part of a bowel preparation for colonoscopy or other procedures. And the protocols may vary between prescribers, and the goal is to have the best visibility of the lower intestines during one of those examinations. And of course, you're going to have your expected side effects. And just to make this, not too long, so, your table 13.4, okay? So table 13.4, has a summary of the common side and adverse effects of those different laxatives. So you can really go into that and look at those common side effects and expected side effects for all those categories of drugs that we just spoke about in regards, or we looked at the anticholinergics, the antispasmodics, and also all those antidiarrheas and what they do with some of those nursing implications. So, um, you know, table 13.4 really kind of gives you a really great overview of the drug itself, the common side and adverse effects in regards to the bulk forming drugs, the stool softeners, the lubricants, and some osmotic laxatives and so forth. Okay, and of course you're going to have certain adverse effects when it comes to these drugs, medications with GI effects. So, medications with GI side effects may cause constipation, and some may cause diarrhea. So here's a list of all of those different types of medications that can cause those effects. And of course, you're going to have your memory jogger with the common drugs used to manage constipation that you'll have there. Okay. Box 13.4 gives you the general nursing considerations um, for drugs, general nursing considerations for drugs for constipation that can cause constipations. This chart here is medications that can cause constipation, and some of the more problematic medications for causing constipation. For example, you have your codeine on this list. That definitely is one of the opioids that can cause constipation. So really, if a patient is any type of opioid, it will definitely cause constipation. Okay, so those are lists for that. And then going back to your book, your general nursing considerations for drugs for constipation. So you have those. Okay. Okay, so that's the end of this recording, and thank you.